So let's continue. Option. So just to make the slide, we stop it. Okay, here, yes, and just share a screen here. So if you would like to say that there is some ground glass, and here, yes, what is your next step? If you say ground glass, okay, sclerosis, increased sclerosis. So this, as we mentioned before, it is a bone lesion, right? Not soft tissue and no joint, because it's away a bit from the joint. And look, periosteal reaction. I didn't agree with periosteal reaction because when you see periosteal reaction, you should see something in this line, which is the periosteum, right? But you don't see any appearance. It looks like the process is here with some expansion. And if you are lucky, you can see that maybe that there is some industrial scalloping here, but it's not very obvious. But yes, you can see something like industrial scalloping here, right? So with this industrial scalloping and this expansion, with the most important to describe when you are in long equation that you describe, it is short zone of transition or long zone of transition, right? So do you agree with short zone of transition that you can clearly know which normal from abnormal, or it is wide zone of transition that you cannot? Which one is more? Okay. Yeah, Nirmin, I know that you would like to jump to the final diagnosis, but to discuss, because you know that it is a bit tricky when you should put other differential diagnosis, right? So I agree with you that probably one of the most important that it will be fibrous dysplasia, sure, which is long lesion in long bone. Okay. So if it is long lesion, long bone, one of them. Okay, let's go to CT. Yeah. So this is the CT appearance, and this is the MRI appearance, and this is the bone scan appearance. So what is going here? Can you describe here? I think this one is now, after all these modalities, it's easy to recognize it. But in X-ray, you should put other differential diagnosis involving infection and other types of tumors. But fibrous dysplasia will be one of the commonest, and you should put it in your consideration. Yes, especially with the ground glass appearance in CT, and in the MRI, you can see clearly that the low signal, yes, low signal appearance, and it's much tricky in bone scan because it take high uptake, yes, high tracer uptake, yes. So we mention it in every place, that giant title in the exam that you should be careful, fibrous dysplasia. One of the good differential for, yes, lymphoma, nice, perfect. Lymphoma is good differential in this case. And as you see, it can present later, like it's not necessary to see it's very young. Maybe he can come to you in after, yeah. So as we mentioned, that patchy sclerotic in X-ray here, and sometimes expansile. In CT, it is ground glass appearance, no periosteal reaction, and this is very important to mention by no, not here. Budget, that's why I mentioned now, Marwa, is that budget in the old age. When you find old age, then you can start to think about budget. But now we are in, yeah, he's young, and also budget have a bit different appearance with cortical thickening. So malignant degeneration is not common. Can be monostotic, polystotic, and in polystotic you will have many questions about syndromes. And one of the most important syndromes that you should know in the text, especially for MCQ aspects, McCone-Albright and what? And Maza-Broward. Perfect. Amna. Nice. So fibrous dysplasia, one of the giant title in MSK and everything. And this is the craniofacial form when it is involved the maxilla and mandible cherubism, McCone-Albright, and Maza-Broward with multiple myxomas. So take care when you find skin, McCone-Albright, and maybe precocious puberty in the clinical form. So this is what is called, we just mentioned it. Yes. And fibrous dysplasia, when it involves the femur, it is have this typical appearance. Also maybe can, yes. Okay, let's go to this case. Yeah. Why you go, Marwa? Why you go and say that it is neurofibromatosis type 1? I know that this is like a common picture that give you, yes, but why? What make you that go direct to mention that it is neurofibromatosis type 1? Perfect. Pseudoarthrosis, nice. And the, yes, Sarah, okay, perfect. And what else? The bowing, perfect. So the anterior bowing, one of the good differential to put neurofibromatosis type 1 and the bowing, yes, also anterior bowing, perfect. So in this case, check the other manifestation with sphenoid wing dysplasia and macrocranium, okay, orbital enlargement, yes, it's very important, neurofibromatosis type 1 in the exam. And check, if you ask, you will ask for the spine to check if this patient have any deformity, like what is this called? Yeah, scoliosis. And in the lateral, yes, you find it to be kyphoscoliosis. Sure, if you find this, it will be like pathognomonic too. What is this one? It is what? Yeah, kyphoscoliosis, Sally, nice. And what is this? Plexiform, neurofibroma, perfect. Zoom user, okay. One of the ribbon reps, okay, and posterior scalloping. Maybe if we have lateral, you can see this posterior scalloping. I think, okay. So this, the stigmata of neurofibromatosis type 1. The differential will be other syndromatic, like Marfan, Ehlers-Danlos, and if it is local in the spine, maybe duralictesia and like a mass. Okay. Something make anterior scalloping, the mesodermal dysplasia, if there is any lymphadenopathy, and aortic aneurysm and TB. Pseudoarthrosis and erotibial bowing, that's what we mentioned. Let's shift to another case, which is maybe short question about differential diagnosis. And here, again, it will be the most important to describe and to mention some, yes. So let's start with what is going here with permeative lytic lesion. Nice, very nice, Nilmi. So lytic appearance and permeation, okay? And there is some sclerosis. Perfect, Marwa. Nice. And what do you think about the soft tissue? So here you mention like a bony lesion and with soft tissue, right? Okay. Wide zone of transition. Yes, this is the word we are waiting. The examiner will wait from you to mention this. Do you like it? Wide or narrow zone of transition. So if it is aggressive lesion, so that's, you will mention that is wide zone of transition. Perfect. Infection, osteomyelitis, it will be one of the good differential. Multiple myeloma, I don't think so, but you put it maybe in the like in the end of the, yeah, but maybe metastasis. You mean metastasis, MM, if it is mentioned, mean multiple myeloma, but I think maybe you mean metastasis, Nermeen. Marwa, yes, aggressive. Ewing, perfect, Shayma. It's fine to mention that could be Ewing. I think Nermeen, lymphoma again, yes, Amna, okay. So we are going to be aggressive, and now you are putting all that. So you should mention in description, and this is, you will take marks in this, permeative, moth-eating appearance, any expression that denote that for the examiner that you know that this is aggressive lesion. Nice. The second, that you should mention wide zone of transition, and don't forget the soft tissue here. Okay. So this 3 words here, it will be the most important to know. Okay. And now I think if you go to the approach, and even if you don't find the final diagnosis as it is, but at least you have the best approach, so you will take the full mark. Okay. So that's what we mentioned. And sure that you will find the age group. And yes, lymphoma can present with everything. So Asma, yeah, lymphoma can show you everything as you will see after. So can make sclerosis, lysis, permeative lesion. Lymphoma and metastasis can behave like everything. Okay. So that's why almost you can put lymphoma and metastasis in every differential diagnosis. Okay. Okay. So now we got the answer. So what is why we, yeah, why Galeazzi, Hassan? Why Galeazzi fracture?
There is dislocation of the,
yeah, dislocation
of the lower ulna.
Okay.
Distal ulna.
And the
fracture of the lower radius.
Yeah, and
dislocation of lower ulna.
Yeah, okay, of the distal radioulnar joint. Perfect. So when you see this one, this is a Galeazzi, and what is the other one which is taking the ulna fracture? What is its name?
Montegia.
Montegia. So Montegia is ulnar fracture, and Galeazzi, which is this one, is radial fracture, right? Amna. Right. Perfect. Okay. It can come to you as a spotting or antimony case, short question. Okay. This one is like just to see in the AB view, and in the other view, you, yeah. So why you think that could be systemic lupus? Nermeen, perfect. Rheumatoid, perfect. So that's antimony is like Jacob's arthropathy, yes, which is systemic lupus. Nice. So they like this picture. You will find it in many texts that similar like this. Why? Because it is like ulnar subluxation at the level of the metacarbophalangeal joints. So when you see this in the level of metacarbophalangeal joints with ulnar deviation in the direction of ulna, so this is what is called, yeah, Marwa, okay? So no erosion. Important to mention that there is no erosions and there is no joint space narrowing. So no joint space narrowing, no erosions. That's why it make away from rheumatoid and away from other arthropathy types. It is not so easy, but at least to know, okay? Yes. So that's what is called Jacob's arthropathy. And it is reducible. I think this one is a bit easy. We mentioned also it before. Yeah. Perfect. So this is a sessile osteochondroma. And you should mention that it is follow the parent bone or the mother bone or whatever bone, okay, which is coming from it. Yeah. And in MRI, you should look in the cartilaginous cap in the T2 and measure it to avoid or to mention that the complication that could be happen with osteochondroma. Yes. And maybe in the MCQ will ask you about the complication. So the most common complication happen the bursitis and mechanical complications and maybe some fractures, and finally the cartilage cap, which is more than 1.5. It denotes that it is malignant transformation. Okay. This one, yeah, we multiple exostoses, which is hereditary type, and here the malignancy increased. And yes, when you find the child and we have one exostosis, search for other exostoses because it's probably is hereditary, right? Let's shift to another one. And I think this one also is a bit tricky, but you should be aware of it. Yeah, Sarah, yes, perfect. Okay, so let's shift to this case. Yes. What do you think about it? Now your question is it a bone lesion, soft tissue lesion, or joint? So it's not joint, so soft tissue, yes, maybe soft tissue, but is a bone lesion? Yes. So it is like mixed, is part in the bone, but the part in the bone is not very clear. In the CT, you can see it clearly that, yeah, it is coming from the bone, right? So nice. One of the best differential you put the Parosteal Osteosarcoma. Perfect, Sarah, Nilmin. Okay, Parosteal, Amna, Marwa. Okay. So Parosteal Osteosarcoma. Why? It is like, as we mentioned, that it is surface lesion, like come just a bit يعني, from the cortex. Yeah, from cortical based, yes. So age is important to know, that is young age, and also the location. So what is the difference between Parosteal Osteosarcoma and this? And sorry, the conventional osteosarcoma? It is like low grade, yeah. So it's important to differentiate, yeah. It's good prognosis. So important to try to differentiate between it and the other one. Better prognosis, nice, yes. Yeah, okay, I agree. And the location, again, okay. It's like the surface, yeah. Here the chemotherapy will not be necessary. You know, in the conventional osteosarcoma, it's necessary to give like chemotherapy, and because osteosarcoma tend to give metastasis, right, and to give also something called escape lesions. But here, the Parosteal Osteosarcoma, it is a bit far from this. Okay. So the treatment will be differential. Yeah. So Parosteal Osteosarcoma, our differential diagnosis will be Myositis Ossificans, but take care that it is the reverse of it. The ossification starts in reverse. Which one is more central? The sclerosis is more central in which one? And which one is more peripheral? This is good question for MCQ. They like it in the MCQ. So this is one is parosteal. In Myositis Ossificans, it is peripheral, perfect, and it's central like here in sarcoma. So central in sarcoma and more peripheral in Myositis Ossificans, Marwa, perfect. So there is one type called Periosteal Osteosarcoma, which also surface osteosarcoma, but is more rare and it is more diaphyseal in position. Okay? Yeah. Again, the prognosis, it is better than the conventional, but less than the parosteal. Yeah. Perfect, Marwa. Okay. This is the appearance in MRI. What is the important description here to mention? What is the most important? Yes, here. Yeah, the periosteum. Yeah, periosteum. Perfect, Marwa. Yes. So aggressive periosteal reaction. Nice. That's the most important to mention. So this is the mark. We'll take the mark in this. Okay. Let's go to this case. I think in this one, even in the practice, you can see something like this. Again, in the any X-ray, you will go to your checklist, and the most important checklist to see first the fractures. You will see the rings, your rings here, your rings here, all types of rings in the pelvis, as you know, that there is many rings. You should follow and see, and go to the dentist, check if there is any lytic sclerosis. Yeah. So yes, maybe something going here, maybe not. Okay, maybe left Nermin. Okay, so your next EVN. No, I don't agree with EVN, because EVN, as you know, it is like you will find something in the X-ray. Even you cannot see, like, mention it until you find something going like sclerosis, and also the location, which is subcortical here. But I don't think that, yeah. So let's talk that there is something going here, maybe nothing, maybe normal, okay? But let's say that osteopenia. In the MRI, you have this typical appearance, and no DDH in this age. You need to go to younger age to mention in the exam. DDH no, septic no, because you need to have wide joint space. We mentioned it before, no. Transient osteoporosis, perfect. Amna, nice. Sally, nice. Shemia, nice. So you have transient osteoporosis. Why? So maybe in the X-ray you don't find something, or maybe you will mention that maybe some osteopenia here. Okay. And in the MRI, you can see clearly that there is, what is the description? What the word that you should take mark if you mention it? What's this word? Nermin say that, okay, unilateral, only involving the femoral head. Yeah, okay, femoral head and neck, and yeah, until metaphysis. No, not geographic. Geographic, you will mention it with a vascular necrosis. Amna, no. Edema, perfect. So this is the word. You should mention only edema. Yes. In the stair image, edema, some effusion, okay, but the most important to mention the edema, because this one is a stair image, and here is very sensitive to fluid. So when you see this image and you want to describe, mention whatever you like, but don't forget to write edema, okay? Then it is differential. The differential, nice. You will, what all that you mentioned, a vascular necrosis, but you should mention that it is not a vascular necrosis because it is different appearance. It is not septic because different appearance. It is not arthritis because it's different appearance, but it could be edema or metastasis or anything else. But edema, sorry, it could be transient osteoporosis or could be metastasis or lymphoma or others, but the description will be lymphoma, yes. Typically, transient osteoporosis happen with the pregnant pregnant woman, right? And in the males, more common in the males, yes, middle-aged males, and it goes spontaneous recovery. So the how to know it, after follow-up, you will know that it is transient. So from its name, it is transient, mean that you will know it with follow-up. So if he asks you what to do, just follow up. Okay, perfect. This is what's called transient osteoporosis. Nice. This one, just to, when you see something in the kids, you will mention many things, okay? Go to your approach, okay? And no, it's not rickets, but maybe you will be considered in the differential, maybe. One of the good differential, yeah, congenital rubella, which is typical appearance, ciliary stalk, yes, this is what's called ciliary stalk, yes. So the differential will be dense amnionized, dense metaphyseal line. When you find this, this is what is called dense metaphyseal line. Then you will go to check this dense metaphyseal line. What could be the differential? Osteopathia striata. So what about lead poisoning? Yes, leukemia, nice. Neuroblastoma, lead poisoning, nice. Sarah, lead toxicity, perfect. Yes. Syphilis, perfect. Scurvy. So let's try to SS, syphilis, and scurvy. And rickets, you mentioned it, nice. Any systemic illness with S, again. Treated rickets, nice. And sometimes they called it variant, but it's better the fibula. Okay, so dense metaphyseal bands is important. More common to see it like this. Yeah, this is more easier for you. Yeah, treated rickets, and this is the, yeah. Okay. Is not scary, but let's talk that is not easy. But when you see it, and this is pediatric patient, look something here, yeah, in the metaphysis, it look like fracture, right? So before you go to any differential, don't forget something called non-accidental injury. And if you find metaphyseal corner fracture, is like very specific, yeah. So do what you like in differential, like put everything you want, but don't forget non-accident, because very, very dangerous that you, it is not, this one is not non-accidental injury or metaphyseal fracture, it's not this. But I mean, if you want to put all differential, starting because it's pediatric, so it starts with all congenital, like you mentioned. And there is something called metaphyseal dysplasia. Just to put it in your differential, just to know the approach, okay? But don't forget the non-accidental injury when you go in your approach, okay? Yes. Yeah, another case. So fractures. Salter-Harris fracture. Can you, yeah. So which type? Type 3. Why type 3? Let's remember, try to memorize. Type 1 is just widening and take the physis, right? Type 2, it take the metaphysis with the physis, the growth plate, yes. And type 3, it takes the epiphysis with the physis, yes. And type 4, it takes both upper and lower, both, right? And type 5 is round. So, yeah. Type 2, because this one, it will be 2, yes. And this one, yes, 3, exact, near me, nice. So 1 is 2, 1 is 3. Yeah. So this Salter-Harris classification, it involves the physis of the growth plate and the upper, lower, together, and round. This one is classic picture, and when you saw it, it's like you will remember it. Sure that in the practice, in real practice, you will put many differential, but in the exam, with this appearance, yeah, what is rat? Yeah, rat ears. So let's try to say that the most important word to say erosion, right? So the erosion is here, is central or marginal? Marginal, yes. So if it is marginal erosion, it is like well formed, like you can see it clearly. So this one is, yeah. So it can happen with not gout. Not gout is overhanging edges. This edges is not overhanging. As you mentioned, man, is not overhanging. Yes. But I agree with you that it is will be differential. Okay, but not psoriasis, not because psoriasis we mentioned it have appearance with productive type. With beside erosion, you have production, new bone formation, and you have penicillin cup, and you have, yes, many no. So I wait. Maybe someone can. It is not easy. I know, but I agree with you that you will put differential. Yes, you can put differential. In the real practice, you will put differential, sure. Scleroderma, if you remember, Amna, we mentioned that it is in the distal acroosteolysis with some soft tissue. No, I know it's not the tool. No, it is not hemoarthrosis, not deposition. It is not deposition. You cannot see this as deposition arthropathy. Nermine, yeah, not rheumatoid, sure, because this type of erosion is not the typical for rheumatoid. But okay, let's have a look. It is not easy. It's something called multicentric reticulohistiocytosis, which is rare. So that's why I agree with you that you will put differential. Important to mention that this is marginal erosion and the distribution also. This one come with malignancy and paraneoplastic syndrome. Maybe. Okay? Just to know something like this. And other appearance when it advanced, how it look. Okay. Let's shift to other case, which is this one. Again, budget, no. If you Nirmin, you know that the budget come more with the old age, so I think this one is not old, right? Do you agree with me that this patient is not? Yeah. So Marwa, yeah, we'll think about infection. Nice, infection, and in this patient, yeah, osteomyelitis is one of the good differential. So let's try to describe. What about the thickening here? You should mention this. Yeah. And there is tunneling. Maybe yes. You can say that there is some tunneling here. So let's talk about that the age in this patient is young. And that you see lytic lesion. Yeah. And there is sclerosis here in the cortical with hyperostosis, right? So description is important to mention that there is hyperostosis or sclerosis here. Yes. Until here, you will put lymphoma, good differential, perfect. Diaphyseal, metaphyseal, nice, Amna. Okay. Infection, lymphoma, good, very, very nice differential. So let's have a look in what, if he show you this one, so now he wants from you something more specific. Why he show you this? Because this, yeah, perfect. Amna, nice. So when you have hyperostosis, remember SAVO. What is SAVO? Synovitis, acne, and pustulosis, yeah, and hyperostosis and osteitis. So this appearance, what is called hyperostosis with osteitis. So remember what is called SAVO, and when you have this SAVO, you should mention CRMO, okay? What is CRMO? Chronic recurrent multifocal osteomyelitis, which we mentioned it already. But it like this medial clavicle. So when you see the medial clavicle, and especially if it come like bilateral and something like symmetrical, so he wants you to say that it is recurrent multifocal osteomyelitis. This entity is hard to come in the exam, but sometimes they, if you are like, yeah, they show you this. If you are hard worker, it can come to you, okay? But we have less than 1 minute to shift to the next session. Okay, so let's stop here until this 1 minute go and take 1 minute break and continue, inshallah, okay? Okay.